Welcome, Mayor Mahan. Good to see you today.
Likewise. Thanks for having me, Scott.
All right, let's get started. In 1969, Governor Reagan signed the Lanterman Act, creating a cradle-to-grave entitlement for people with developmental and intellectual disabilities, now serving roughly 500,000 Californians at a cost of about $20 billion a year. There are no equivalent entitlements for people with severe mental illness. Do you believe California should create such an entitlement for serious mental illness? And if so, what specific revenue or budget trade-offs would you use to pay for it?
It's a great question. I think that we absolutely need to increase our commitment to safe in inpatient and indoor environments, supportive environments for those suffering from mental health disorders. We see a crisis on our streets, far too many vulnerable neighbors who are literally dying out there because of lack of a safety net. Don't know that the state can completely take this on for everyone. As long as families can support their loved ones, the state should play a supporting role. But for those who don't have family members who are there to support them or can't anymore, the state has a responsibility to step in and not leave some of our most vulnerable neighbors to live and die on our streets. As a mayor of a big city, uh, seen the impacts, the devastating impacts of untreated, unsupported addiction, mental health care, and I think that it's cruel, frankly, to leave people out there. So I've been a real advocate for expanding inpatient treatment. I think the state needs to add state mental health hospitals. I think at the county level, we need accountability for adding beds at all levels of acuity. And I think cities have a role to play from a land use perspective, outreach, and supporting our mental health courts.
And so from your statement, does that imply, or is that your way of saying that you do support an entitlement?
I do. I think that the word entitlement implies a potential breadth of applicability and cost that I need to see. I need to see the model. I want to see the mathematical model on how we do it. Where we are today is we are so far behind that I want to start by fully implementing Prop 1 and adding the 10,000 treatment beds, including residential treatment. I would hold Sacramento accountable for adding hundreds of state mental health hospital beds to provide relief for our counties in the most severe cases where people need long-term custodial care. I want to implement Prop 36, care courts, SB 43, and really get that system working. These ideas are all heading in the right direction, but in implementation, we haven't seen the positive impact that we should be able to see. On Prop 36, we've seen San Diego County, the DA there took it upon herself to connect with behavioral health and the judicial bench, bring people together. She has, in her first year of implementation, 1,000 people in a treatment pathway. 96% of people are choosing treatment, and overdose deaths for homeless residents in San Diego County are down 25% in 1 year. So these tools can work if we adequately fund and implement them and stitch together our systems. So working toward an entitlement, yes, but in a state that has over 100,000 people living outdoors, many of whom now have serious behavioral health challenges, I think the truth is we're going to have to move toward that system. I don't think it's something we can just do overnight.
Okay, well, the current governor has invested over $16 billion toward behavioral health transformation. Share with us, what is the one major structural outcome that you believe must be in place at the end of your first term for those investments to be considered a success? And further, if you could explain to us, how will you measure progress toward that outcome?
Absolutely. The bottom line is we have made it too slow and too expensive to build in California. I stood with the governor in support of Prop 1 because we need the 10,000 treatment beds that the measure promises. But land use and local control and slow approval processes have led to far too beds even getting under construction or being, taking existing buildings that need to be remodeled. We have to be able to move faster in California. And just as an aside, it isn't just our deployment of capital investments to expand our healthcare system that's at stake. It's the transformation of our schools, it's home building, which is a linchpin of economic opportunity. It's upgrading our energy grid to hit our climate goals. It's being able to build new infrastructure like high-speed rail. The current regulatory environment isn't working for us. So at the end of my first term, I will pursue CEQA streamlining that will make it much easier and faster to site and build, or if appropriate, remodel structures to be able to provide the outcomes we need. And those outcomes are reductions in unsheltered homelessness, people in an appropriate setting with case management, with a connection to care, and with data around graduation rates. Some folks may need to be in an institutional setting for the rest of their lives, but for the vast majority of people, that's not the case. Our goal should be to stabilize people, help them to get healthier, and really get to as much self-sufficiency as possible on a per client basis. And I want to track all of those real world or hard outcomes in people's lives and then optimize our system to keep increasing those over time. But today, whether it's CEQA, permitting, licensing, we take years to get through the red tape and bureaucracy to deliver the outcomes that we need. And I'll be laser focused on being more efficient and getting to those outcomes faster.
Okay. Well, California still, you'll have plenty to work on because California still has the largest homeless population in the country. But in
Sadly.
2025, we did see a 9% drop in unsheltered homelessness, breaking a 15-year trend of growth and suggesting that housing first and supportive services may be starting to work. What do you see as the core drivers of homelessness in California, and what would you prioritize to keep unsheltered homelessness declining?
Well, San Jose and Santa Clara County have really built the model for this. We've reduced unsheltered homelessness in San Jose by nearly 1/3 over the last 4 years. We've added more interim housing and transitional housing than any other city in the state. We've taken an all of the above approach. It isn't housing first or something else. It isn't just brand new apartments or just prevention. We've really taken an entire continuum of solutions that work together. And I'll just briefly outline them. In partnership with our county, we've built the nation's leading prevention model. Notre Dame University did a randomized control trial and showed the efficacy of our prevention interventions. We pair short-term rental subsidy with intensive case management and help people to bridge through an unexpected health issue or job loss or messy divorce or whatever that triggering event might be, and we keep people indoors, stably housed. In the middle of this continuum is our commitment to ensuring that none of our vulnerable neighbors are forced to live out in a tent encampment in misery at risk of exposure to the elements, overdose death, violence, and all the rest. We've built a very robust interim and transitional housing system and moved thousands of people indoors, over 30% of whom have already graduated to permanent housing. And that gets to the last part of the continuum, which is building affordable housing. And in San Jose, under my leadership as mayor, we have continued to put hundreds of millions of dollars into affordable housing. We've also given permit approvals, entitlements, and permits to a number of affordable housing projects that only needed tax credits to get under construction. And so I think it's really this all of the above approach of preventing homelessness, ensuring no one is left to suffer out on our streets because we know the immense human suffering, the impacts on the broader community, the fact that once someone's been out there for years, it's harder and harder to help them turn their lives around and more expensive, and they've suffered more. And then it's saying yes to housing. In San Jose, I'm proud that we've led the state in adoption of ADUs. We were the first city to condoize ADUs. We've had a very robust program of funding affordable housing, but not just with local subsidy. We also say yes to every affordable housing project that uses tax credits from the state and federal government. And we've removed barriers to building market rate housing because we need all housing types to meet demand. We broke the housing market, and really our high housing costs and homelessness are a public policy failure, first and foremost around the lack of housing supply.
Well, many mayors are calling the homeless housing assistance and prevention funding to be ongoing and guaranteed as one potential solution. Do you support locking in ongoing state homeless funding to local governments? And if so, what performance or accountability conditions would you attach?
It's a great question. You're talking about the HAP program that the state has funded. I've been one of the leading advocates in the state for ensuring that we have $1 billion a year commitment. I was the first, maybe the only gubernatorial candidate still in this race who committed to keep HAP funding at $1 billion a year every year as an ongoing commitment. But paired with that is the other part of your question, which is so important. We have to be outcome focused in government, particularly when we're investing in third parties. And with HAP dollars, you have money going to cities, to counties, and to COCs, continuums of care, which are often boards made up of local elected officials, nonprofit leaders, and individuals with lived experience and others. The outcome that we need is not going to be achieved by simply dividing the pie equally. It needs to be based on performance. We need to work with cities, counties, and COCs, and maybe in some cases their efforts need to be merged and they need to be incentivized to integrate their approaches. That's what we've been doing in our city and county. We said the city can take the lead on interim, the county has taken the lead on implementing prevention and building affordable housing. The county has behavioral health services that we need in our interim system. And so we're integrating our city and county approach into a single service delivery model. So I think the funding is a carrot, hopefully more than a stick, but is a way to incentivize at the local level the best practices that lead to the outcomes we need. And what are those outcomes? It's the things we've been talking about. First and foremost, nobody should be living outside on the streets. It's awful for those individuals. Their situation deteriorates. They're more likely to be at risk of violence and death. And the ability to help them, it becomes harder and harder to help people turn their lives around. And the impacts on everybody else are so significant. And the fiscal cost. So everybody should be indoors. That's got to be priority number one. We should be reducing the inflow of homelessness by investing heavily in prevention that works, to have fewer and fewer people become homeless every year. We need to, when we get someone indoors, quickly connect them to case management, stabilize them, and help them turn their lives around. And the long game is we have to hold every city and county accountable for building its fair share of housing at all levels of income. And we shouldn't be pitting one type of housing against another. Market rate housing adds to the housing supply. And over time, it ages into affordability and takes pressure off the rest of the system. So and it's worth noting, when we build affordable housing through government, we often spend 30% more per unit than the market spends to build market rate. So I'm not for demonizing anybody, but I just think we need all of the above, all of these different approaches to increasing housing supply to bring it in better balance with job and population growth.
It's interesting you say that because without that all of above, many Californians are frustrated by the visible encampments and public disorder caused by people who are too sick to voluntarily accept help. And some civil liberties groups are warning that expanding civil commitment and court order treatment approaches like the care court risk coercing people with mental illness. Give two specific examples that illustrate where you are personally and would draw the line between an individual's right to refuse treatment and the public's interest in safety and order. And explain any legal changes that you might make if you would propose to move that line.
Yeah, it's one of the toughest issues facing California because we pride ourselves on our individuality, our difference and diversity and free expression, and we really believe deeply in civil liberties. And at the same time, we see immense suffering on our streets. We see thousands of people who have died. In fact, in the last 10 years in California, we've had nearly 50,000 people die on our streets, nearly half from overdose and suicide. And I don't think that that's compassionate. I don't think it's progressive. I've had personal experience with these issues. I have a cousin who spent a couple of years on the streets due to severe addiction. I remember stories of my aunt and uncle just being devastated and looking for him on the streets. I have a very close friend of mine who, when we were about 20 years old, was diagnosed with severe bipolar disorder. And I spent quite a few weeks in a mental health hospital with him on the East Coast, where we were going to college. So I've seen that when people are deep in the throes of addiction to something as addictive as meth or fentanyl or the combination of the two, or have a serious behavioral health, mental health disorder, the compassionate thing to do is to intervene. And yes, that may look like it may in fact be a temporary suspension of certain civil liberties. Now, I think when that happens, there have to be very strict protocols. There have to be checks and balances. Has to be oversight. Uh, if somebody is in a drug court, you need a clinical, or if somebody's in a mental health court, you need a clinical opinion. And so there has to be a level of professionalism and oversight and accountability. And I don't believe, for the vast majority, vast 99+% of people, that long-term institutionalization in say a state mental health hospital is ever necessary. But our failure to intervene more aggressively, immediately, and for a short duration is actually leading to more long-term issues and more suffering and more death. And so the model I would like California to experiment with is one in which we make our drug and mental health courts more robust for mandating treatment, including involuntary treatment, for short periods of time. I think the duration matters. I think if you catch it early and get somebody stabilized for 30 days in a supportive environment, and then have residential treatment where you have transitional housing, the person's totally free to come and go, but they're not back in a tent encampment. And not that everybody who's in this situation is homeless, to be clear. Neither my cousin nor my close friend started out homeless, at least. But without that intervention early and for a reasonable duration of time, and having a slightly higher bar for re-releasing someone, we're letting people deteriorate and die. And so the current 5150 hold doesn't really work for many people. You talk to police officers, firefighters, nurses, the people in the emergency psychiatric service, they see the same people endlessly, who come in, get hydrated, get in a slightly better position, answer the 3 questions, and they're back out in 24 hours. And then eventually it becomes so severe, they're back in the emergency room, they're back at EPS, they're in the county jail, or they've just died of an overdose. Surely we can do better.
Exactly. But one of those things in terms of the interventions you're talking about, that getting that type of help to those individuals, is that current involuntary commitment standards rely on a danger to self or others, or being gravely disabled. And
Yeah.
many families and providers say these thresholds are both too vague and too high.
I
What would you,
completely agree.
okay,
Yeah.
so the question for you is this: what would you change in terms of the legal standard for involuntary commitment in California? And if so, how exactly would you change them?
Well, I think you've hit on the core legal issue here. And I worked with Senator Susan Eggman when she was serving in Sacramento in the legislature on this very issue. This is what SB 43 was about. And I don't think we did enough there, frankly. I think that the interpretation of danger to self and gravely disabled is too narrow. And I will say right now, what I would do as governor is create, and I don't want this to drag on forever or be a 1,000-page report, but I would create a diverse stakeholder group that includes people with lived experience, clinicians and physicians and psychiatrists, lawyers, and even though I know they're very resistant, representative from the ACLU. And but I would task that commission with giving us a durable legal theory for where the line should be and a clearer definition that's informed by science, but has as its North Star saving lives by intervening earlier and more pragmatically to help people get on a different path. And I think the data at the population level in California is very clear in that it's not working. When you have tens of thousands of people in a decade die on your street of overdose and suicide, the pendulum has gone too far, meaning the definition of danger to self or gravely disabled is too narrow. But I think what's important is as we expand that, again, clear definition that expands it, because I think if you're cycling through these systems and you're out on the streets passed out and you're refusing help and you're endlessly cycling, you are a danger to yourself. Whether it's of overdose or getting hit by a car, at some point living outside and refusing help repeatedly and ultimately ending up in emergency rooms and county jail, at some point there's got to be a threshold where you're a danger to yourself. That's at least a common sense definition, but we need a clearer clinical and legal definition. I totally get that. That has to then come with oversight, with accountability, with the ability to kind of scrutinize, have we gotten it right or not? Because I don't think you ever just make a change and it's fixed. There's always unintended consequences. So we got to really look closely at it. We're talking about human beings and their freedom and their lives here. And it's important to me, I think that it's really important that we start with that, whatever expansion of definition comes with a commitment that any involuntary commitment is shortish term, long enough to provide stability and care, 30, 60 days, but short enough that we haven't done irreparable harm by restricting someone's freedom.
And I think we will leave it there.
Thank you so much, Scott.
Mayor Mahan, pleasure to meet you.
Likewise, pleasure to meet you. Thank you so
Bye.
much.